I will.
All right, thanks.
Uh-huh.
All right, guys, let's look at this information on chest tubes. This is just sort of a quick and dirty introduction. Have any of you taken care of a patient with a chest tube before?
Yes.
Okay, so you know a little bit about it, but there's a lot to go on with it. I mean, most of the time, the Atrium uses those Atrium brand Oasis chest tubes. Why do we put in chest tubes? Well, it depends. Couple of things you need to remember. That pleural space is that line is between the chest cavity and the lungs itself. It holds about 50 mLs of that lubricating fluid. Remember, that's one of the reasons we give kids surfactant if they're born prematurely, because they haven't developed it themselves, that hold that alveoli open. Because that lubricating fluid coats both that parietal pleura and the visceral pleura, it creates a pressure that keeps those lungs expanded. If you get excess fluid or air in there, then what happens is the lung can't fully expand and it leads to respiratory distress. So why do we use chest tubes? Probably the most common reason is a pneumothorax. Pneumo meaning air in that pleural space, caused by trauma, lung disease. You may see it with an invasive pulmonary procedure, like when they do a lung biopsy. Forceful coughing, any surgical complications, and they can occur spontaneously. A lot of times you will see patients with something we call a bleb, B-L-E-B. And a lot of times when they forcefully cough, it can spontaneously cause a pneumothorax. Basically, if you are draining air from that pleural space, that chest tube's placed in that anterior chest at about the second or third intercostal space. So remember, air rises. Now, one of the other reasons we see that people get chest tubes are hemothorax. They get blood in that pleural space by either blunt or penetrating trauma. Like blunt trauma would be like a steering wheel that might cause bleeding into that space. Penetrating trauma would be like a gun or a knife wound, or perhaps a broken rib. Now, basically, if you have a hemothorax, it's going to drain fluid. That chest tube is placed at the lung base. Now, what if you have a hemopneumothorax? What would they do? Where would they put the chest tube there?
Would you have two tubes?
Yes, ma'am, you certainly would. You get the gold star.
I appreciate it.
So what you will see is they would have one to drain the air, one to drain the blood. Now, you can also put in a chest tube for pleural effusions, and that's excessive fluid in that pleural space. A lot of times you see that with people with pneumonia or left ventricular heart failure, which you're going to learn about in the next unit of perfusion. Pulmonary embolism, cancer, complications of surgery. And sometimes these pleural effusions can be very thick and difficult to drain. Okay, sometimes it can just be pus that comes out. So you can use the chest tube for that. Empyema is another name for pus from an infection. And it has to be drained no matter what the small amount is. If you have an empyema and leave it, it will still continue to fester, and you will have a patient that can become septic from that pus that's left in that place. Now, sometimes they will place chest tubes preventatively after cardiac or pulmonary surgery to drain blood that may leak postoperatively. They may also use it to prevent what we call cardiac tamponade. Okay. Cardiac tamponade basically is a fluid collection in the pericardial space. And so what happens is you get a fluid buildup around the heart, which causes it to decrease in the effectiveness of the pump. It can also be used in still fluids like chemotherapy or sclerosing agents. The chest drainage unit, that's the one that you saw on the video. It's traditional chest drainage, the collection chamber, the water seal, the suction control, and it can drain large amounts of air or fluid, okay? How much could that chest tube drainage system in that video drain before you have to change it? Any idea?
2,100.
I think it was 150 mLs. Okay, so what you will see is that it can drain quite a bit. So you don't have to change it on a daily basis. You just need to change it if something happens and it got knocked over and it wasn't working well, or if it got full. Now, there are also very small portable chest drainage units that you may see a mechanical one-way valve instead of a water seal chamber. Those are for your patient that needs drainage only, but not suction to re-expand those lungs. A lot of those are used by your EMTs or EMS systems or your patients that are transported by helicopter, like Life Flight. Okay. Heimlich valves are those one-way flutter valves. They will drain air when that patient exhales. With that Heimlich valve, you need to remember to keep that collection device upright and vented in order to prevent buildup. You may see these come in the emergency room. We typically do not use them whenever you are in the hospital. Now, if you have a patient that has chronic pleural effusion, you may have what we call an indwelling pleural catheter. It drains fluid only. It can be done at home every 1 to 2 days or when they're short of breath, okay? A lot of these are done, especially with our patients that have pleural effusions from cancer. In other words, this catheter can be left in place, and often public health nurse or home health nurse comes out and assists with that drainage. Otherwise, this patient would have to come to the hospital every 1 to 2 days, which can be quite a chore if you've got a very sick patient. We need to position this patient for comfort depending on the site inserted. Sometimes they will be lying on their side. Sometimes they may be lying flat in bed. When that advanced care provider, usually the physician, puts in that chest tube, they anchor it with a suture to keep it from falling out. As the nurse, we need to have an occlusive dressing. Usually what you will see is a dressing with a Vaseline gauze applied to that insertion site around the tube, and then they will put a 4x4 or one of the dressings around on top of that occlusive dressing and just tape it down. One of the things that we need to make sure as nurses that all of our connections are securely taped. Remember, the chest tube has to be taped to the drainage system. And then usually part of our nursing care is to make sure that they have chest x-rays to confirm the position after placement. And then usually they do them daily to look for lung re-expansion, okay? What are some of the risks or complications? Well, bleeding, okay, is usually minor, but if it's extensive, they may have to go to the OR to have it replaced. Infection is a problem, but typically what you will see is that usually occurs the longer the chest tube is in place. If it's only for a couple of days, usually there's not a problem with infection. Now, you may get something that we call subcutaneous emphysema. It's characterized by swelling in the face, neck, and chest, and it crackles on palpation. Basically, it feels sort of like Rice Krispies under their skin, okay? Sub-Q emphysema is caused by air that gets into the skin tissue and from the leak from that area. As the nurse, we're going to monitor vital signs, and how often that will depend on what their condition is. Probably every 4 hours at the most, and it may be more frequently. We want to make sure that we assess their breath sounds bilaterally during that period when we're doing our vital signs. We're going to look at our insertion site. Now, this is not going to make you very, the patient's not going to be very happy with you, but we want to encourage that patient to cough and deep breathe. Yeah, I know that you got this tube sticking out the side of your chest, but coughing and deep breathing will help to re-expand that lung. We want to make sure our connections are taped securely. And this is something that we need to make sure is that collection apparatus, the drainage system, has to be below the level of that patient's chest. Where I see this is a problem most of the time is whenever the doctor tells the patient, get up and walk. And so what they do a lot of times is carry it like a pocketbook on their arm, or they hang it on their IV pole and they hang it too high. So that drainage unit has to be below the level of their chest. Other things, we want to check that water seal and suction control chambers frequently to see if there's an air leak. If there is an air leak, is it because our connections are not taped securely? Or is there an air leak because air is escaping from that patient's lung? All of our drainage has to be assessed for color and amount. Most of the time, what you should anticipate is either serous sanguinous fluid or pus or some other color. Bright red is not a good color. It may indicate increased bleeding. we're going to measure drainage every 8 hours or more, depending on that patient's condition. Now, if I have a patient that has just come back from chest surgery, or they've had open heart surgery, I'm probably going to measure that drainage every hour. And I'm going to let the physician know if there's more than 100 mLs of drainage. We definitely want to document our assessment, including about the chest tube, but also about their lung sounds, their pain, okay? We want to reposition them frequently. Think about it, guys. If you have someone with fluid on their lung and that tube sits in one area, it's only going to drain that fluid in that one area. It's like when you're drinking from a liquid from a straw, like from McDonald's straw. You're going to move that straw around to try to get all that milkshake up. So repositioning them frequently will increase the ability of that tube to drain the fluid that we need to get out. We want to avoid loops in that tube. You don't want it hanging low, like with your Foley catheters. We don't want to manipulate them like stripping or milking. You might do gentle pressure on that tube to like move a clot down, but you don't want to be aggressive about it. That squeezing of that tube and releasing will help move those clots along. Now, one of the things that we always want to have in the room in case we need it is a pair of clamps. Typically, we avoid clamping a chest tube except when we're replacing that drainage unit or if we're trying to locate an air leak. Or sometimes the physician will order that tube to be clamped to see if that chest tube is ready to be removed. But remember, avoid it except in those 3 particular manners. Typically, you'll see that they can remove a chest tube when there's little or no drainage, when the air leak is gone. If that patient is breathing normally without respiratory distress, that chest x-ray shows lung re-expansion, no residual air or fluid. The other thing you might see that they will remove the chest tube for is if there are fluctuations in the water seal chamber, when those have stopped. Now, with removing a chest tube, this is not a staff nurse or bedside nurse procedure. It's usually done either by a physician or it may be done by the nurse practitioner with additional education or the physician's assistant with additional education. When that is removed, we want to monitor them very closely with a very thorough respiratory assessment. One of the things we want to monitor for is signs and symptoms of hypoxia or hypoxemia. And what might be some of those signs?
Cyanosis.
Cyanosis, that's a fairly late one.
The late one, yeah.
Confusion.
Confusion.
Low
What
oxygen
else?
level. Let's see.
Looking at their O2 sats. Okay. Just as an FYI, guys, I just recently read a study that said that O2 saturation monitors like an O2 sat were basically developed for Caucasian or white patients, and that sometimes they can miss hypoxia in people of color. So that's one of the things that you need to be very careful about. You know, if you see that this patient is confused and restless, but their O2 sat says they're 98%, I would further investigate. So just making sure that you investigate further. Sometimes you might have to get an arterial blood gas in order to figure out hypoxia on people of color. Okay. Let's see. All right, that's pretty much all on chest tubes. There's a question, will we be working with chest tubes, EKG, et cetera, on this clinical go-round? Yes, if you're in the ICU, and yes, if you're in the ED, okay? So one of the things that we did is we like to do a little bit about this, just to give you a taste of some information about these things. Because if you have a patient in the ICU with a chest tube, remember you can see those on Med-Surg as well. Those of you that are on PCCU will probably see patients with chest tubes. Those patients on PCCU are on telemetry. And so you need to be able to recognize or understand what's going on if they have EKG changes. Okay? Any questions about chest tubes?
Are we going to get an opportunity to like practice this at some point?
At some point, yes. Okay. We will not have time to do it tomorrow during the psych sim, but I'm hoping that we will do some simulation in 212. So I will give you the opportunity to practice some of this. Now, one of the things that you'll see in 213, however, is a lot of EKGs and recognition and treatment, nursing care, as well as code management. In fact, that's what Ms. Rumble and I were doing this morning with our 213 students, is running them through the EKG recognition and management of cardiac arrest in the lab. So you will get that. But chest tubes, you know, maybe I can do some of that in 212 where you will actually get hands-on. Okay.
And is this testimonial material for the exam Wednesday?
No, it is not. This is an FYI clinical prep type stuff.
Okay, thank you.
Okay. So you may be responsible for some of this in clinical, but not testable. However, it will help you probably a little bit about Ms. Rumble's perfusion on the next unit. Okay. All right. Why don't you guys, I see that it's 1:51. Why don't you take a break until 2 o'clock? And then we'll come back and do some more of this content. Okay?
Thank you.
Mm-hmm.
weird. My hose.
Yep.
Okay. Oh, no.
I'm gonna turn my volume off.
Okay. Hey guys, this is Miss Rumble. You're going to be getting a condensed version of EKG monitoring, simply because in 213 is where you get all of that information, and you are tested on that information. Okay, so I'm going to share my screen. Okay, so basically I'm going to condense this for you guys. But again, what controls our heart? The ability to beat. Well, the heart's the most unique muscle in the body in that it can initiate an impulse, transmit an impulse, and respond to that impulse, okay? And that is due to the autonomic nervous system. The autonomic nervous system with the sympathetic control, it's going to increase your heart rate. With the parasympathetic control, it decreases the heart rate. These are terms that you will see in your drug book that refer to rate, which is chronotropic, conduction, which is dromotropic, and strength, which is inotropic. An example of that would be digoxin. Digoxin has a positive inotrope effect. It enhances contractility, but it has a negative chronotropic effect. That is why you always check a pulse and before you administer digoxin. This is to remind you that, like I said, the heart is polarized. It can initiate impulses, transmit those impulses, and respond to those impulses. So how does that really work? It's due to the movement of electrolytes or ions that you see at the bottom of this slide. Sodium and calcium. Sodium is your most abundant extracellular electrolyte. Potassium is your most abundant intracellular electrolyte. So within the cell, the intracellular space, you've got potassium and mag. And in the extracellular space, you have sodium and calcium. And what happens is when potassium and mag start to move out of that cell and sodium and calcium start to move into the cell, that is when contraction will occur. So that movement of those electrolytes occurs just prior to the contraction that you see on an EKG. This is the fancy theoretical one, but just know that it's the movement of those ions that cause contraction, or it's the medical term is depolarization. And then when the potassium and mag start to move back into the cell where they belong, and sodium and calcium move back out to the extracellular space, that is where you're going to have ventricular filling. And then the heart gets ready for the next beat. So this is just a summary. So your heart is polarized. It can initiate an impulse, transmit that impulse, and respond to that impulse. Depolarization is atrial and ventricular contraction. repolarization is ventricular, atrial, and ventricular filling. Did you record this? Okay. All right, so electrical, that movement of ions occurs just before the contraction. So a reminder about your conduction system. You always want your SA node to be the pacemaker of your heart because it emits impulses at 60 to 100 beats per minute, theoretically. So that's going to be the optimal heart rate to maintain adequate perfusion. Okay, but what you'll learn is that the heart will never stop until it just can't do any more, because the brain is going to always send a message to the myocardium. If the brain's not getting enough blood flow, it's going to cause a heart rate to increase. So if the SA node fails, your AV node will kick in. But you can see that can be a problem because the impulses being delivered are at 40 to 60 beats per minute. So that's not going to be optimal for perfusion. And if all else fails, your Purkinje fibers will try to emit impulses at 30 to 40 beats per minute. And that is not going to sustain perfusion. Here's a picture showing you where your SA node is, your AV node, and your Purkinje fibers. So what do you actually see on the EKG? Okay, well, first of all, we are going to put electrodes, those little pads or round circles that have gel. We're going to place our electrodes on the patient. You have to have, if you can see this where my mouse is, you've got limb leads, right arm, left leg, right leg. And then you have chest leads. These are called your V1 through V6. And that is what you need to get a 12 lead EKG, which is the best pictures of the heart to see what the myocardium is doing, okay? These leads actually have, they're like, almost like, think of it like a battery. They have negative and positive. So if you go back up here to this slide, when the heart is pumping blood and it travels toward a positive lead, that's what makes your QRS upright. If it's moving away from the positive lead, that's why you'll see the QRS downward. It doesn't mean there's anything wrong. So you're really getting 12 different views of the myocardium to determine what is wrong with this patient. So after you've put your electrodes on and your leads, you're going to see this. Well, this is a textbook picture. What you see right here, it's the P wave, and you can see that represents atrial depolarization or atrial contraction. Your QRS represents your ventricular depolarization or ventricular contraction. And then your T wave represents your ventricular filling or ventricular repolarization. The atria are filling as well, but that impulse is so small you will not see it on the EKG. Okay, this is just a summary. You've got to have limb leads, those are called bipolar, and you want chest leads, which are your V1 through V6. If you're going to place your electrodes on the patient, make sure that their skin surface is clean You may have to shave the men, place over areas of minimal movement and avoid bony areas. You want the best picture possible to give you the best 12-lead EKG so that treatment can be administered to this patient. This is simply showing you the upright QRS. So the blood is going toward a positive lead. And if you look down here at this one, the blood is going away from the positive lead, and you've got a downward QRS. If you look at it very closely, you can see negative, positive, positive. So they are polarized. And those leads that you connect to your electrodes, then it's sent to the cable and goes up to the monitor. EKG paper is very special. I'm not going to go into detail. You will learn that in 213. I just wanted you to see what these are: your atrial contraction, the P wave. The QRS is your ventricular contraction, and the T wave is your ventricular filling. Okay, that is what you're seeing on the EKG. If you're in the hospital, the easiest way to count an EKG is to you count your number of QRSs in a 6-second strip, and you will multiply that by 10. So 1, 2, 3, 4, 5, 6, 7. So that's approximately 70 beats per minute. So if you're in the hospital, you're printing strips, that way you can look at that and try and count the heart rate. These are just more specific ways. I'm not going into detail. So this is showing you, okay, we're going to count our QRSs: 1, 2, 3, 4, 5, 6, 7, 8, 9. Times 10. So this heart rate is 90 beats per minute, okay? This strip is simply showing you how we get a 6-second strip, okay? There's like 15 big boxes here and 15 here. I'm not going into PR interval and QRS interval. You will learn about that in 213. These are normals. So let's look at just a few rhythms, okay? So this rhythm that you see, it has atrial P wave before every QRS. It is regular, and we're going to count 1, 2, 3, 4, 5, 6, 7, 8. Heart rate is 80 beats per minute. This is normal sinus rhythm. This is what you want for your patient to provide optimal perfusion. Now this is, you've got a P wave before every QRS. The rhythm is regular. And when the rate is less than 60 beats per minute, this is sinus bradycardia. May or may not be a problem. In this one, you have P wave before every QRS. It's regular, but look at the rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. The rate is 110 beats per minute. This is called sinus tachycardia. You want to identify, is a patient in pain? Are they anxious? Have you had too much caffeine? Diet pills will do this. So this is sinus tachycardia, may or may not be a problem. Okay, we're going to go through, I think, 3 or 4 dysrhythmias. The rhythm that you see in front of you is the most common atrial dysrhythmia in the United States. It occurs primarily in patients that are 65 years old and older. So as the population ages, we're seeing more and more of this dysrhythmia. If you notice, there is no, I think I put the wrong one. You guys need to ignore that. I'm sorry, that is slide 28. I did not mean to put that in there. Here is the rhythm I want you to look at, slide 29. So just mark through slide 28 because I want you to get a short review. So as you can see, there is no distinct P wave in this rhythm. You have 1, 2, 3, 4, 5, 6, 7, 8. 8 QRSs times 10 is 80. What you see here are called fibrillatory waves. If you imagine, open someone's chest, take their atria. So you're going to put it in a bowl like red Jell-O, and you shake it really, really fast. That is what the atria are doing. This is called atrial fibrillation. Okay, atrial fibrillation. This rhythm has an apical radial deficit. So if you auscultate the apical pulse, and then you have someone palpate the radial pulse, the rates will be different. So as nurses, you always assess an apical pulse for 1 full minute, and it is recommended to get a manual blood pressure, okay? Because the atria are not pumping blood, these patients are at risk of an embolic stroke. This is the #1 reason for an embolic stroke. So they need to be on anticoagulant therapy. This is another example of atrial fibrillation. It is called an irregular rhythm. There's no P wave and the rhythm is irregular. This is atrial fibrillation has variable rates. And when the rate gets high, like 150, 160, 180, then this can compromise the patient just due to the rate. And oftentimes we'll give an IV calcium channel blocker. What you see here, this wide and bizarre beat is called premature ventricular contraction, or PVCs. We all have a rare PVC. As long as they're rare, that's not a problem. But if they're together like this, that is a problem. You need to call your physician, give them vital signs, labs, medications, and continue to monitor that patient. This is another example of PVCs together. So you need to alert the physician about this. You do not want the patient to go into this rhythm. This is called sustained VTAC, sustained ventricular tachycardia. Often students refer to it as the tombstones. You need to identify that this patient is unconscious, that they do not have a pulse, and the first thing you do is call a code. Then start your compressions. What you need is the crash cart, and you want to use your defibrillator to defibrillate or shock them out of this rhythm, okay? So this...
That lab looks great. It does.
This is another example of tombstones or sustained ventricular tachycardia. Again, identify that the patient is unconscious, that the patient is pulseless. Call a code, start compressions. You need a crash cart and you need a defibrillator to shock them out of this rhythm. Your last strip is called ventricular fibrillation. You will check, make sure that the patient is unconscious, that they are pulseless. Call a code, start compressions, because you need a crash cart. And this is another rhythm that you want to defibrillate. As students, if you are in a code situation, you can only perform CPR. The current guidelines are that you change compressors every 2 minutes, because if the compressor becomes fatigued, that patient's not getting adequate perfusion during that time. So this is just a very short, brief summary of some of the most common rhythms that you will see. There are many more that you will learn and be tested on in 213. So at this time, do you have any questions? No? It's a lot. It's a lot of material. Like I said, when you're in in order to shock someone, isn't there a specific protocol? That is exactly right. And that is what you will learn in 213. That specific protocol comes from the American Heart Association. It is called Advanced Cardiac Life Support. And that is what hospitals utilize as far as our shock and medications that we give. And that is called Advanced Cardiac Life Support. It is put out, that is published by the American Heart Association. What type of wave does an AED have to detect? The AED detects ventricular fibrillation and sustained VTAC. It detects those two rhythms as shockable rhythms. And if you haven't ever used an AED, you will in 213, as well as run through a code. Any other questions? You're welcome. You're very welcome. I know it's been probably a long day for you guys too. If you think of any, you can always email me. It's 2:22. You want to start at what, 2:30? So yeah. They can. Okay, let's start back at 2:30. Ms. Hyde will complete this information, giving you some basic information about what to do, which you know as a student you're going to be doing CPR. But what you would do as nurses in a code situation. Again, it's very brief, it's very simple. It's something you can take these to clinical and learn from every situation. But in 213 is where you will learn the whole shebang, and you will be tested on it at that time to prepare you before you become a nurse. Okay, guys?
Thank you.
Uh-huh.
Thank you. Thank you.
Uh-huh. All right, Renee, how do I make you? How do I make you host? I don't even see you. Oh, here you are. Okay, let me mute.
over now is a little bit about code management. What we've got on the, let me share my screen with you. I'm afraid I just got rid of it. Oh, well, that's all right. I'll open it up again. Hang on one second. Okay, sharing screen. Okay, so one of the things that happens is that whenever patient cardiac arrest, there is not perfusion. And unfortunately, what happens is that unless we restore that perfusion, that patient is going to die. So that is why we initiate the American Heart Association's basic life support, and in the hospital, advanced cardiac life support in order to restore that patient's perfusion status. This is a copy of what we call a MOST form, M-O-S-T, Medical Orders for Scope of Treatment. One of the things that's very, very important, okay, is that whenever you have a patient that is outside of the hospital, okay, that if they have a DNR or do not attempt resuscitation order, that they carry this form. Okay, this is a order set that not only talks about resuscitation, but it talks about what types of treatment that they may want to have. Okay, so if a patient is on palliative care or hospice care and outside of the hospital, this is a form that they can fill out not only to talk about cardiopulmonary resuscitation, but any kind of medical interventions that they may want to done. Okay, so a MOST form, as I said, it's an outside of the hospital. Now, what if they come in the hospital? Typically, what will happen is that MOST form will be honored, but there needs to be a physician order in the chart for that do not attempt resuscitation. Okay, so remember, in the hospital, we need an order on the chart in addition to this form. Now, one of the things that Ms. Rumble talked about when she was talking about treating some of those lethal arrhythmias was defibrillation. What defibrillation is an electrical charge that depolarizes the cardiac tissue. It basically stops that electrical impulse from the SA node to the AV node. And then what we hope happens is that heart sort of reboots, like whenever you restart a computer. And it allows that normal pacemaker, which is the SA node, to take over and start again. Most defibrillators are biphasic now, meaning that energy goes both ways instead of monophasic. This is a very, very important point, a very good high KDOT. we always say all clear before defibrillating a patient. You as a student, if you are in a situation where they are defibrillating someone, if they yell all clear, then you better be away from that bed and not touching that patient, because if you are, you can receive a shock as well. Typically what I say is all clear, I'm clear, everybody's clear, I'm going to shock now, so that it gives people time to get out of the way. Now, that is with a defibrillator. If you have an AED, you're going to attach that to the patient and it will analyze. One of the nice things about AEDs is it walks you through the steps. It will only shock if it's indicated, if it analyzes that patient's heart rhythm and a VFib or VTAC or ventricular tachycardia is recognized. One of the things we're going to do after is, if that defibrillation is unsuccessful, what we want to do is to improve the metabolic environment of those cardiac cells. Remember that fairly recently, the American Heart Association changed the sequence to CAB. You know, it used to be ABC, airway, breathing, circulation. Now it's circulation, airway, breathing, okay, for us, the lay providers. But what we want is for people to pump fast, pump hard. We want 100 to 120 beats per minute. For an adult, that needs to be at least 2 inches for compressions on the chest with full recoil. And for 2-person CPR, it's 30 compressions to 2 ventilations. If you are in a patient's room, we want those ventilations to be with 100% oxygen, okay? 1 breath every 5 to 6 seconds, which will result in about 10 to 12 breaths per minute. That's called rescue breathing. Now, if that patient needs to have their airway secured or a tube placed in their airway, it's called intubation. And that usually is done by a respiratory therapist or an anesthesiologist, okay? One of the things that we will do with that airway in place is monitor their CO2. If it's less than 10 millimeters of mercury, we want to, again, push harder, push faster to improve our CPR quality. One of the other things that we will see is that part of the advanced cardiac life support protocol is to give meds that may help to reverse that particularly lethal dysrhythmias. Remember, we have a patient that we are doing CPR on, and so they have no spontaneous circulation. It only circulates blood whenever we're pumping on their chest. So each medication that we give has to be given with at least a 20 ml bolus of normal saline. And to help it to get to the core of the body, we want to elevate that arm. Okay, gravity works. Now, if you can't get an IV, they may do it intraosseous. And if you've never seen an interosseous, let me know and I'll show you tomorrow. Okay. ROSC is return of spontaneous circulation. That means that they come back. What we want, if that happens, is that CO2 to be 35 to 40, our O2 level to have an O2 greater than 40%. We want that blood pressure greater than 90% systolic. Any acid-base imbalances need to be corrected. And then we need to look at labs, because a lot of times during these situations, sodium, potassium, magnesium, and calcium may be altered. Now, our ACLS algorithms, again, those are published by the American Heart Association, the same people that do BLS. Basically, for ventricular fibrillation or pulseless VTach, our two main treatments are going to be defibrillation and CPR. The med that we're going to give is epinephrine. It's a catecholamine, which basically makes the heart more susceptible to receive that electrical charge. So hopefully that rhythm will reverse and revert to a sinus rhythm. Okay. Epi or epinephrine is given as a 1 milligram IV push, and it can be given every 3 to 5 minutes. Now, some of the other antidysrhythmics that you may see, amiodarone, again, it can be IV or IO. The initial dose is 300 as a bolus IV push. Now, one of the things that you can see is that it says second dose 150 milligrams. That is usually given after about 3 to 5 minutes. Remember, you're doing CPR and you may have defibrillated in between that. Another medication that can be tried is lidocaine. And typically we will give 1 to 1.5 milligrams per kilogram for that particular dose. 2 minutes of CPR, defibrillation, and then in 3 to 5 minutes, you can give a second dose. That's again 0.5 to 0.75 milligrams per kilogram. Now, there are a lot of causes that may cause ventricular tachycardia or ventricular fib. You may hear them referred to as the 6 H's and the 5 T's, okay? And that's just a mnemonic to help you remember them. Hypovolemia, blood loss from some reason. Hypoxia, low oxygenation. Hydrogen ion, they're in acidosis. Or hypo or hyperkalemia. Hypothermia and hypoglycemia. Those are the 6 H's. The 5 T's are tension pneumothorax, cardiac tamponade. Remember, cardiac tamponade is when you get fluid in that pericardial sac and it limits the ability of the heart to beat properly. Toxins, like poisons, or basically think about someone in kidney failure. Those waste products building up. Thrombosis, pulmonary thrombosis or coronary thrombosis, blood clots, PE, or there is a blockage of one of those coronary arteries, okay? Again, VTach. Looks sort of like tombstones from the side, doesn't it? And unfortunately, that often is going to what's occur if this rhythm is not corrected. Then another example, okay? This one is just sort of upside down. The reason that it looks different from the first is that it's looking at a different lead, okay? Now this is ventricular fibrillation. Really, that you don't see a P wave, you don't see a QRS. What's happening is that heart is just sort of quivering or fibrillating. So there is no perfusion here with this patient. Typically, what you may see first is ventricular tachycardia that deteriorates into VFib. Now, atrial fib, as Ms. Rommel said, is one of the most common dysrhythmias that we see in the United States. Typically, if it's been present for greater than 48 hours, they use some of the agents or some of the treatments with caution, because if you take them out of that rhythm and start perfusing them, some of those little blood clots that may have developed in that atria break away, and it can cause either stroke or pulmonary embolism, okay? Untreated AFib is one of the most common reasons of embolic stroke in the United States. One of the things that we also can do is we control the rate. We don't want AFib, people with AFib, to have a heart rate of greater than 120. And typically they will give them calcium channel blockers like cardizem or diltiazem or beta blockers to slow that heart rate down. If they have impaired heart function, digoxin, diltiazem, and amiodarone may be drugs that they use. Now, if you have a patient with a new onset of AFib and it's less than 48 hours, they can do what they call cardioversion. And that's whenever they use a defibrillator in a specialized manner. The joules or the amount of energy that they use is much lower, and it's synchronized with the QRS. So that what happens is when I push the button to synchronize, it will sync with those QRS waves. And when I push the button to discharge that electricity, it will only discharge on that QRS, hoping to reset that heart and stop that AFib. Now, they usually will use cardioversion less than 48 hours because, again, the chance of clots is decreased. And new onset, because the longer that someone is in AFib, the less likely that cardioversion is going to work. Another example of AFib, you see this very wavy baseline. All of these are P waves, but none that you can see distinctly. Again, AFib is an irregular rhythm. So I've got all of these P's here, but no QRSs. One of the things you have to worry about with AFib is that even though there's a QRS wave here, which means that the ventricle beated, that may not result in perfusion in that patient. So that's why Ms. Rommel was talking about taking that apical radial pulse rate. to see what the difference between the two are. Another example, this one is a little higher rate, in fact, much higher. It's about 180, okay? So what you will see is that a lot of times whenever you have heart rates this high, perfusion decreases even more because this high a heart rate does not allow for ventricular filling. And when that heart does beat, you have a very low cardiac output. Now, SVT or supraventricular tachycardia. SVT, a lot of times people say, I feel like my heart's fluttering out of my chest. A lot of times it's caused by high intake of caffeine. We see a lot of SVT with Red Bull shots, especially Red Bull and vodka. But you can see it what we call paroxysmal, meaning that it starts suddenly, stops suddenly, and sometimes they don't know why. But SVT, because of the rate, again, this one's about 175, can result in decreased perfusion. Now, the med of choice for narrow QRS tachycardia or PSVT is a med that we call adenosine. And it is given as a 6 milligram IV push. Okay. Now, this one of the things as a nurse that you may observe if they give it on PCCU or in the ED is this is a medication that has a 6-second half-life. So you have to push this med in over 3 seconds and then flush behind it to get it into their system. So usually it takes 2 nurses to push. One to push the med. The second person changes the stopcock and pushes the flush. Now, one of the things that you will see with adenosine is it's like a reboot of your computer. You know, when your computer is sort of messing up and you get tired of trying to fix it, you just turn it off and then turn it back on. Basically, that's what adenosine does. And if you've got this patient on a cardiac monitor, which you should if you're giving this medicine, is that you will see flatline. And typically in about 15 to 30 seconds after this med has been infused, hopefully they will start with a sinus rhythm again, a regular heart rate. Okay? But that 15 to 30 seconds sometimes is the longest 15 to 30 seconds because pretty much everyone in the room's holding their breath to see if it's going to start back again or not. Now, if it doesn't start back, then you're going to initiate your code situation where you have CPR and the other medications that we would give and defibrillation, okay? All right, so those are some of the ones that you will see. Any questions about those?
Thank you, Ms. Hyde.
Bryn, yeah, you can switch. I will take a look at it whenever I get home. Okay. All right, guys, I've got that it's 2:55. Since Dr. Bowie said that you are having problems with the video and sound, I will let you watch the video on code management on your own, okay? Are there any questions about what to expect for tomorrow?
Miss Hyde, I still haven't gotten the okay from Miss Fink yet for tomorrow. And I sent her my negative results. It's Becca, by the way.
All right. Make sure you follow the schedule. Show up at your screening time. Dr. Bowie will be downstairs to get you checked in. And what I want you to do at that time is to come up to room 214. Okay. What you will see in that room, I've got blue painter's tape as X's on the places that you can sit, because that way you're socially distanced at least the 6 feet apart. Okay. And then we will take you into the small simulation lab in smaller groups and do the simulation, myself and Mrs. Chandler. Okay. We will go ahead and read through that case study, and you can bring it if you want to, print it out, or you don't have to. I will have a copy of it so that you can see it. And I will get you familiarized with the simulation lab. Becca, you're fine. Come on in. So if there are no other questions or concerns, I will end the Zoom call and allow you to watch the code video on your own, just so that you're familiar with what may happen during your clinical rotation, okay? Again, as I said before, you will be exposed to some of this on PCCU in the emergency department as well as the ICU. And we didn't want you to be totally lost. So tomorrow, we're going to do a psych simulation. And as I said, you'll check in downstairs and yes, come to 214. Okay. That's usually the PN classroom, but it's closest to the small lab. So that's the room that we're using. Sit in the desk that have the blue X so that you're spaced out.
Okay.
All right, guys.
Thank you.
Thank you.